And joining us now here in studio, Lisa Priest, health reporter with the Globe and Mail, and it's nice to have you in that chair again.
Thank you.
So the world changed on January 1st. Hospitals became subject to the Freedom of Information requests. So specifically, what does that now mean?
Well, that means you will be able to find out in the public how much a CEO makes, but you've always been able to know that. Now you know the perks and some of the other things that were hidden, like, as you mentioned, golf club memberships and the like. You can also find out other information as well that'll sort of be tested, because there's lots of restrictions, like there's certain things on teaching and clinical outcomes you may not be able to get, but you could do sort of a hunting if you were a reporter or a patient trying to find out about how your local hospitals run, or maybe how that hospital stacks up to other hospitals. Oh,
so it's not just the juicy, sexy stuff that the papers have been splashing. There's actually some medical stuff that we can find out now too.
Possibly.
Possibly, yes. Okay. Why was it that we were able to find out salaries before, but we couldn't find out the perks?
Well, that was the Sunshine List, which has been around, I think, 14, 15 years, where anybody who made over $100,000 a year would have their name publicized and their taxable benefit. And then there was that other amount of money that was not considered taxed, which I think now is, and those were the other packages that were offered to CEOs, whether they used them or not.
Why did the government make this change?
I think the Ontario Hospital Association will say they asked for it in 2009, but there's been a lot of controversy with e-health, and there was also an Auditor General's report that came out a little over a year ago that talked about high-cost consultants and lobbyists to hospitals, and that caused an uproar. Just this lack of transparency and a seemingly lack of fairness on what happens in the public system and why we can't know about it.
Have you talked to many hospital CEOs about this and how either thrilled or not they are to have all of their previously private compensation packages spilled all over the pages of newspapers like yours?
Well, it's interesting, isn't it? I mean, they've known for months this was coming out, so some boards acted quite quickly to sort of, remove car allowances. Some CEOs had very simple packages, maybe some educational requirement, and that was essentially it. Then other ones had either, I find it hard to believe some CEOs were demanding, cosmetic surgery. It must have been a package that was handed to them, a laundry list of things. But now there's CEOs now are saying, I didn't get plastic surgery, and there's things they didn't even use.
I'm not the one.
Exactly. But the optics of these kinds of perks just seem so over the top. And male CEOs, they're getting the tax planning and the car leases, and the women are getting, Weight Watchers and these other things like cosmetic surgery. It seems kind of crazy, but it's really just about, that's the kind of stuff that gets the public going, and hospitals voluntarily, well, they were asked to. Most of the hospitals put it up on their website so people could easily find it.
Did you, when you either published this in the paper or on the Globe Mail website, did you get people emailing back or phoning in saying, they're getting what? I mean, what was the reaction like?
Well, there's always a group of people who believe that public servants make too much money and don't work very hard. And we know what the reality is. I mean, these people work very hard, and some do make a lot of money. I think the real problem is that you don't have, the standards that applied in medicine as you do to here. It's not transparent. But there are people that are going crazy, like, people who have been in the private sector, who have been under wage freezes, who are making all these concessions and feel like they're sort of carrying this on their back while other people are making money. Although I will note they've been under pay freeze as well, the CEOs.
Bob Bell's the guy at the top of the list. He's the guy who runs the University Health Network, $1.75 billion enterprise, for lack of a better expression. How's he holding up under all this? He's really had his face and name splashed all over the place.
Knowing Bob the way I do, I mean, he's very, I think he would not be that bothered by it. His salary has been out there a long time, and he's used to being in the public eye. I don't think anybody likes being a half-page photo in a newspaper, not ours. But certainly this kind of focus, you do wonder about, how do patients feel, how does the public feel in terms of confidence of their hospitals? Okay,
in which case let's move on to whether any of this newfound transparency is likely to have any significant change on the way healthcare is actually delivered in the province of Ontario. What do you think?
Well, I think with the Excellent Care for All Act, which is separate from the FOI, but kind of dovetails with it in the sense that you have to tie CEO's compensation to performance as a part of it, and there should be measurables on that, and there should be at-risk pay, and it works very well. They've had some of this in larger hospitals for some time now. Now everyone's going to have to figure out a way to do it, but it's going to inspire that, and hopefully there'll be a move towards having some kind of framework so that when a board does decide on CEO compensation, they have something to work with. because a lot of the mid-sized hospitals, the salaries have a huge variation in pay.
How about the patient experience? Is that likely to change as a result of any of these changes we've been talking about?
That's a very good question. The patient experience should really change, because ultimately the patient is a taxpayer and they're the most important person in all of this. And some of the pay is going to be linked pay for performance, and do you drive up those patient satisfaction numbers? But it's very hard to do, because the system is sort of an acute care system that's kind of broken. So they're going to have to find really novel, ingenious ways to do this. But that is sort of the most important thing, I think, in hospitals right now.
What information do we still not have access to that you would still like to know about because you think it's in the public interest?
Well, you might want to know something about maybe a doctor's privileges. Did they lose them? Did they get them back? I mean, you won't be able to find things like that. There are certain services that you won't be able to find about. I think probably the heavy scientific data, like maybe you know, how many, if you tried to ask how many people died in a certain unit, you would have trouble finding out that. So there's some clinical things that actually used to be published some years ago in a report card that stopped being published publicly. But those kinds of things you might want to know. But you might even want to know, and this you might even be able to get, you know, if some people put together a proposal to do some operations after hours that were going to be cheaper to the healthcare system than what the public system pays them, and it got refused. I mean, things like that. I mean, I think a lot of reporters will be getting brown paper envelopes saying, check this out.
That's tricky stuff, though, sometimes, right? I mean, if there is a unit or if there's a hospital where they seem to have a particularly, you know, bad series of outcomes in a particular area, it may have to do more with the clientele or the, you know, how rich or poor the neighborhood that they're servicing is in. I mean, can't hospitals get a bad rap for sort of unfortunate reasons for that reason?
You have to be careful, certainly, like critical care units, you know, 1 out of 5 patients typically die. I mean, that's a very high number. That's sort of, you know, there's reasons to explain that, because they come in from trauma and are not at death's edge. The other things too have been studied and can be controlled. I think we probably should have more of that, but I don't think making that transparent necessarily causes patients to shop around for hospitals. I mean, you're going to go to the emergency that's closest to you, and if you're waiting for a hip replacement, you're going to get the doctor that you've been given most of the time.
You're going to go to the emergency that's closest to you, unless there was an article by Lisa Priest in the paper the day before that said, this ER, 90% of the people who go there die. Then you're probably not going to go there, are you?
No, probably not.
And but you wonder whether that kind of, you know, whether that kind of transparency, as it were, can have an adverse effect actually on patient care at the end of the day. You wonder about that?
Well, you know, in America, if it's done properly, I don't think it does. I mean, they've done this in America, where they've published outcomes on cardiac bypass surgery and showed huge variations in rates, and actually the system got fixed. It was in New York, in great part because of that transparency, because not necessarily because patients will shop from place to place, but because the providers say, oh my God, you know, I'm that bad, or I'm not as good as the next person. I'm going to show you how good I am. And sometimes it's something simple that they fix, but sometimes it's post-op or complications that's out of their hands. So there are ways to do it. The thing is to do it with care, and to not just sort of toss it out like seeds to a bird. You have to really know what you're doing.
Are people in the healthcare system concerned that with all of this new transparency and this new information that they have, that somehow this information will get politicized in a negative way and it won't be good at the end of the day?
It's an interesting question. I mean, I think certainly the perks and the publishing of them didn't do a lot of good. I mean, you've got to wonder about these people who sort of put some of these packages together. The benefits, they were probably just, in some cases, CEOs probably just handed these benefits, right? Never used them, probably didn't even know about half of them, and now they're coming out saying, I didn't get plastic surgery, I didn't go to Weight Watchers. I mean, it's kind of awful in a way. So I think, but it really feeds into that societal feeling that people in the public sector are getting an easy ride and have these great pensions, and their wages keep increasing when we're in tough times. So I think people are going to be looking for really strong austerity measures.
Our last 20 seconds here. Can you imagine a potential hospital CEO would avoid going for a job in the province of Ontario because of the transparency now required?
No, not at all. I think it's a fantastic job. A very small talent pool can do it, but I think it's just one of those things that's incredible to do.